Dear friends and colleagues, welcome to the NVM Cardiology Meeting Reflections for Radcliffe Cardiology. My name is Nicolas Van Mieghem, and today I will do a preview of the late-breaking clinical trials as they will be presented at the upcoming TCT 2025 conference in San Francisco. You may be used to a different format, but times are changing, and I guarantee you we will invite friends and colleagues to do this again in more conversational format moving forward. But let's get started with the first trials, and the first one revolves around the use of drug-coated balloons. An interesting trial, a very important trial, I guess, is going to be the SELUTION DeNovo study by Christian Spalding. This is a randomized controlled trial that is comparing sirolimus-eluting drug-coated balloons versus drug-eluting stents in de novo coronary lesions in an all-comer setting. Well, we have to take that with a grain of salt because left main coronary artery disease, chronic total occlusions, STEMIs, and unstable non-STEMIs will not be included in the trial. Still, more than 3,000 patients were enrolled in this trial at 50 sites in Europe and Asia, and the primary endpoint is target vessel failure rate and their components at 30 days, 6 months, and then annually up to 5 years. I think this is a very important study because there is a lot of hype around the use of drug-coated balloons and expanding indications. The question is, are there early penalties for using only a balloon and not a stent to scaffold the stent or the treated area? And then also over time, do we see a setback because of the stented material? And is that an advantage of drug-coated balloons, or are there other issues at play? So I'm very interested in the results of this trial. Another trial on drug-coated balloon is the OCVC-BIF study from Japan. This trial is specifically focusing on patients with bifurcation lesions, and patients who have a provisional approach will be randomized to either the stenting procedure followed by a final kissing balloon, what you always would do, versus putting in the stent, then do a drug-coated balloon treatment of the side branch, and then followed by a final kissing balloon inflation. So this is a very interesting concept. The primary endpoint is restenosis of the side branches documented by a scheduled or symptom-driven coronary angiography during 9 months of follow-up. But there are some issues where I have some questions. Well, first of all, which drug-coated balloon is going to be used? But then also, if you do a drug-coated balloon inflation and then you follow up with a final kissing balloon inflation, will that not affect with the drug deposition in the region of interest? Will you not remove the drug again? So that's one question that I have. The other one is, why not add more granularity to the primary endpoint by using invasive imaging, ultrasound, intravascular ultrasound, or OCT? I think that is a missed opportunity. 300 patients will be included in the study, so it's going to be of interest whether we see a difference at 9 months. Then let's move to coronary calcium modification technologies. This is always a very important topic at the latest interventional cardiology trials and meetings, at the latest cardiology meetings. Let's go to the first study, that is the shortcut RCT by Suzanne Barron. This trial is comparing cutting balloon angioplasty versus shockwave lithotripsy prior to DES implantation in patients with moderate to severely calcified coronary arteries. An interesting study. It's investigator-initiated from the United States, enrolling 410 patients from 22 sites. And the primary endpoint is the post-procedural stent area at the point of maximum calcification as measured by intravascular imaging. To be honest, I expect non-inferiority. I don't think that lithotripsy will outperform cutting balloon, but it all depends on the phenotype of the lesions that we're seeing in this trial. Is it excessive calcium? Then the benefits of Shockwave may come into play. Otherwise, I'm a little bit concerned that we will see some kind of findings that are similar to what we had with the Eclipse that evaluated orbital atherectomy in more than 1,600 patients, but also showed no difference with standard of care. Another interesting study on calcium modification is by Matthias Bossard from Luzern. This is a single-center study, the the Victory RCT. And this is a non-inferiority study comparing super high pressure non-compliant balloons, so the OPM balloon, versus, again, shockwave lithotripsy for completeness of stent expansion in severely calcified lesions. I think this is an interesting trial, well done. 280 patients have been enrolled, and they are looking at final stent expansion as assessed by OCT. Also here, I would expect non-inferiority, but again, it will depend on the calcium severity of the coronary lesions that were treated in the study. Now, let's move to another topic, treatment of intermediate high-risk pulmonary embolism. Last year, we had the PEERLESS randomized controlled trial that already hinted towards the benefit of thrombectomy in the context of pulmonary embolism. And also in the STORM-PE RCT, we will look at the effects of thrombectomy, aspiration thrombectomy, mechanical aspiration thrombectomy, but this time not with the Inari device, but with the Indigo aspiration system. And then again, for the treatment of intermediate high-risk acute pulmonary embolism. And patients will be randomized to either the thrombectomy arm or conventional anticoagulation. 100 patients have been enrolled in the US, New Zealand, and Poland. And the patients are at intermediate high risk. The primary endpoint is a change in the ratio between the RV and LV dimensions at 48 hours as assessed by CT. I predict a positive trial. I think we already know from PEERLESS that included more than 500 patients that thrombectomy works in the context of intermediate high-risk patients. In PEERLESS, they were comparing versus catheter-directed thrombolysis. Here, we are comparing to anticoagulation. So we'll see whether we also have this faster recovery of RV dimensions and RV function with the Indigo device. Let's move to the transcatheter valve space. And first, there is some interesting data coming in TAVI space because we will see the 7-year clinical and echo follow-up results from the PARTNER 3 low-risk randomized controlled trial. And this is important because there have been rumors that the curves were separating in favor of surgery in low-risk patients with aortic stenosis that were randomized to either surgical aortic valve replacement or TAVI with the balloon expandable SAPIEN valve. In the PARTNER 3 low-risk trial, the mean age of the patients was less than 74 years old. So this becomes very relevant because patients will have a longer life expectancy. And now we will see, indeed, whether at 7 years we will see this clear separation of the outcome curves in favor of surgery or not. I must say that I don't expect meaningful differences between the two treatment strategies, but there has been a lot of turmoil the last couple of months about the PARTNER 3 trial, so definitely something to follow up on. And there is also the 10-year PARTNER 2 intermediate risk trial data that will be presented. I think this trial is a totally different animal. The mean age of the patients was 81 years old. They were also at higher operative risk, so you would expect by default higher mortality at 5 years, but definitely also at 10 years. So how many of those patients will be still alive at 10 years? That's going to be the question. And again, I don't foresee any differences in treatment outcome between TAVI with the balloon expandable SAPIEN valve versus surgery. But we will have to put all these data in perspective of, for instance, the NOTION randomized controlled trial that already provided 10-year outcome comparisons between surgery and the self-expanding core valve system in low-risk patients with severe aortic stenosis. So I think this is going to be interesting data, and it will also help us delineate a little bit the open questions that relate to durability and also catch-up phenomena in terms of outcome of trials. Now let's go to the mitral replacement, so TMVR for mitral regurgitation. I think an important study that will be presented is the ENCIRCLE trial. This is a prospective registry in the US, but also in Europe. We were also part of that trial. and it's looking at the outcomes after patients have been treated for their mitral regurgitation with the SAPIEN M3 system. And this is a very interesting and almost unique TMVR system where you use a two-step approach. First, you implant a docking station to wrap around the cords, and that dock will then be used to help anchor a modified SAPIEN 3 29mm valve. I think the technology is very intuitive. It also is totally different from these one-step approaches where TMVR is done with these very large self-expanding systems. I think the risks are different. But also, still, what is of interest is what is the screen failure rate of this trial? Are we talking about a niche product, or is this technology that will become available for more patients with severe mitral regurgitation? Other things to look at is what were the access site complications, because the French size profile of these systems are somewhat larger than what we're used to, and what was their conversion to surgery, and what was the early mortality? I think these are interesting topics to follow of this trial. More PCI trials. Well, I think another interesting trial is the NOBLE trial that will present the 10-year clinical outcomes. And to bring it back to your memory, NOBLE trial is a randomized controlled trial evaluating patients with left main coronary artery disease, randomizing them to PCI or surgery, CABG. Patients were enrolled between 2008 and 2015. 1,200 patients were randomly assigned to PCI or CABG. And we already know that at 5 years, the MACE rate was higher for PCI as compared to surgeries, 29% versus 90%, but there was no difference in mortality. It was all driven by non-procedure related myocardial infarctions and revascularizations. I'm not so sure whether at 10 years we will still see a difference between the two strategies, because typically, as if you do longer follow-ups, curves might start to converge again. But then again, and so for instance, in the SYNTAX trial at 10 years, there was also no difference between surgery, CABG, and multivessel or left main PCI in patients that were treated with first-generation drug-eluting stents. So in SYNTAX, the 3-vessel disease cohort had a benefit at 10 years for surgery, but there was no difference for the left main patient. So it's going to be interesting to see how NOBLE will compare to the SYNTAX trial. Another interesting trial is the PROCTOR trial. This is a trial that has been designed and steered from Amsterdam by Paul Knapen. It's a multicenter randomized controlled trial. It was investigator initiated and had received support by Abbott. The trial enrolled 221 patients and then was ended. And we'll figure out the reasons why it was ended and why not the original 580 patients were included in the study. The trial enrolled patients in the Netherlands, Belgium, Germany, and the UK. And it's interesting because it was comparing the treatment of a dysfunctional venous bypass by PCI versus the treatment of the native vessel. So patients with a dysfunctional venous bypass, they were randomized to either treatment of the venous bypass or leave the venous bypass alone and target the native vessel that was bypassed with the venous bypass. So I think this is very interesting. The primary endpoint at 1 and 5 years is major adverse cardiac events. And I think this was a very ambitious initiative, focusing on a niche population, but very relevant for everyday clinical practice. So kudos to our friends in Amsterdam. With that, I'm coming to the end of this NVM Reflections, this preview for TCT 2025. Stay tuned for the wrap-up, as I will be doing a wrap-up after TCT 2025. Maybe I'll see you in San Francisco. Otherwise, stay well, be healthy, stay safe, and I'll see you for the wrap-up. Goodbye.